Welcome to this explainer. Today, we're diving into the sudden, fascinating, and honestly pretty terrifying medical mystery of facial paralysis. It's one of those conditions that can literally happen in the blink of an eye, or, well, the sudden inability to blink an eye, and it completely alters how we express ourselves and interact with the world. Picture this. You wake up, look in the mirror, and half of your face just won't move. What in the world happened? It's a super alarming scenario, right? 1 second, everything is totally normal, and the next, your reflection looks completely different. But don't panic. By tracking the amazing journey of the 7th cranial nerve, we can completely demystify exactly what's going wrong under the surface. We're going to break down this complex neural highway together to understand exactly why this happens and how we fix it. So here's our roadmap for today. 1. What is facial paralysis? 2. Causes and risk factors. 3. Pathophysiology and clinical presentation. 4. Diagnosis and differential diagnosis. 5. Management and potential complications. And finally, 6. Prognosis and prevention strategies.
Section 1. What is facial paralysis? Introduction and epidemiology.
Okay, so the 7th cranial nerve is quite the complex traveler. Our clinical sources tell us it actually starts way back in the pons, popping out at the pontomedullary junction. From there, it journeys through the internal acoustic meatus right alongside the vestibulocochlear nerve. It's carrying a massive payload. We're talking motor, parasympathetic, and sensory fibers traveling all the way from your brainstem, squeezing through the rock-hard temporal bone of your skull, out to your face. Once this traveling nerve finally exits the skull through the stylomastoid foramen, it enters the parotid gland. And right here, it branches out into 5 highly specific terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. These 5 branches are literally responsible for every smile, every blink, and every single frown you make. So you can guess what happens if there's damage anywhere along that path. The signals get cut off, and boom, paralysis.
When it comes down to it, Bell's palsy is the absolute #1 most common cause of acute, one-sided peripheral facial paralysis. And a really interesting fact here, it affects adults totally equally, regardless of gender. Now, while anyone can get it, in developing regions, things like middle ear infections, otitis media, and other viral infections are massive contributors to why it holds that #1 spot.
Section 2. Causes and risk factors. Etiology and what puts you at risk.
So what actually triggers this sudden shutdown? Well, the causes are really all over the map. You've got idiopathic inflammation, which is basically what we call Bell's palsy when we don't know the exact trigger. Then you have infectious agents like the herpes simplex virus, varicella zoster, or even Lyme disease. It can also be purely structural, think temporal bone fractures or a parotid gland tumor pressing on the nerve. And to top it off, your risk definitely goes up if you have underlying conditions like diabetes, if you're immunosuppressed, or even if you're pregnant.
Section 3. Pathophysiology and clinical presentation. The tunnel analogy and physical signs.
To really understand the mechanics of this, think of the facial canal inside the temporal bone as a rigid, incredibly narrow tunnel. There is literally zero give. So if a virus causes even a tiny bit of inflammation and edema, the nerve swells, but the bone around it, it doesn't expand an inch. The nerve basically gets crushed inside its own canal. This totally disrupts conduction and cuts off all those vital motor signals trying to reach your face.
But remember, this nerve is a serious multitasker. It carries multiple types of fibers, so the symptoms go way beyond just muscle weakness. A crushed 7th cranial nerve also severs parasympathetic and sensory signals. That means patients often complain of intensely dry eyes, losing their sense of taste on the front 2/3 of their tongue, and a really painful sensitivity to loud sounds, which is called hyperacusis.
Physically, the presentation is incredibly drastic. You'll see sudden asymmetry, a drooping mouth, and that totally flattened nasolabial fold, the laugh line from your nose to your mouth. But the most striking feature is often lagophthalmos. That's the medical term for when the eye simply cannot close completely. It looks alarming, but more importantly, it leaves the cornea dangerously exposed and vulnerable.
Actually, let's try the clinical test together right now. Go ahead, raise your eyebrows. Now, shut your eyes really tight. Give a big smile. Puff out your cheeks. If someone has a peripheral lesion on their facial nerve, they just won't be able to do these symmetrical movements on the affected side. While one side moves normally, the damaged side is going to stay completely flat and totally motionless.
Section 4. Diagnosis and differential diagnosis. The forehead twist.
Okay, this is absolutely crucial. When a patient comes in, doctors have to figure out immediately if this is a localized nerve issue or a life-threatening brain emergency, like a stroke. This right here is the ultimate aha moment in differential diagnosis. Because the upper facial muscles actually get signals from both sides of the brain, an upper motor neuron lesion, like a stroke, will spare the forehead. Meaning, if they can still wrinkle their forehead but the bottom of their face droops, you're likely looking at a central issue, like a stroke. If the entire half of the face is paralyzed, forehead included, it's peripheral. That's your Bell's palsy.
Doctors have to be super quick to distinguish peripheral paralysis from these severe mimics. Bell's palsy might be the most common, but getting this wrong is a huge deal. You definitely do not want to miss a stroke, a serious autoimmune disorder like Guillain-Barré syndrome, or a tumor hiding out in the parotid gland.
So how is it officially diagnosed? Well, mostly it's a clinical diagnosis done right there in the exam room using those exact physical tests we just did. But sometimes deeper investigations are critical. They might order an MRI or a CT scan to completely rule out structural lesions or strokes. Blood work is standard to check for underlying diabetes, and serology is a must to look for Lyme disease if you live in an area where ticks are common. They might even use electrophysiological tests, like an EMG, to measure the exact severity of the nerve damage.
Section 5. Management and potential complications. Healing the nerve.
When it comes to treatment, you gotta act fast. Doctors typically hit this head-on with steroids, like prednisolone, to aggressively shrink that swelling inside the facial canal. If they suspect a virus is to blame, they'll add an antiviral like acyclovir. But remember the eye. Because of that lag of thalamus, absolute vigilance is mandatory. We're talking artificial tears, thick ointments, and an eye patch to prevent the cornea from scratching or ulcerating. Facial physiotherapy exercises help keep the muscle tone up, and in super rare, severe cases, they might even need decompression surgery.
If it's not treated early, patients face some tough complications. Obviously, there's the risk of permanent weakness and contractures. But there's also this incredibly frustrating condition called synchesis. Basically, as that crushed nerve tries to heal and regenerate, it can accidentally miswire itself. So a patient might try to smile, but those cross signals involuntarily force their eye to squeeze shut instead. It is incredibly distressing.
Section 6. Prognosis and Prevention Strategies. The Road to Recovery.
But here is the good news. The prognosis for Bell's palsy is generally fantastic. The vast majority of patients are going to see a complete recovery within 3 to 6 months. That said, the odds do drop a bit if the patient is older, if treatment was heavily delayed, or if those initial EMG tests showed severe total nerve degeneration.
Now, you can't always predict a sudden case of idiopathic inflammation, but to protect your cranial nerves from this terrifying experience, there are things you can do. It is absolutely vital to get simple ear infections treated quickly before they can spread. Manage viral infections, and if you have a chronic condition like diabetes, keep it in strict check.